Okay. So hello everyone, I'm Dr. Tarjani Dave. I work at Every Prasad Eye Institute, and I'm going to talk to you about mucormycosis, the black fungus, and the battle that we are fighting within this war of COVID-19. I hope I'm clearly audible and my slides are visible. Please show me a thumbs up if one
Yes,
of you.
yes, please
And
go ahead.
yes, they're visible. Right. Thank you so much. So the objectives of today's talk are to take you through the several aspects related to mucormycosis that you see on the right-hand side of your screen via 10 points that I'm going to talk about. Now, this is one of the most important slides. Why has this become an urgency? The reason is that if you look at the survival rates after mucormycosis, it's about 60%, which means 40% individuals will succumb to the disease. This is a relatively high number, and it's a very fast spreading fungus. Now, move on to the last point on this busy slide, and you understand that those patients who have cerebral involvement from mucormycosis, in those patients, the mortality is actually as high as 80%, which is really high. And hence the urgency in recognizing early as well as initiating treatment early for these patients. The second point is about the fungi which produce mucormycosis. It's not just mucor, but it's the entire order of mucorales, any of these organisms which can actually go ahead and produce mucormycosis. And you'd be able to differentiate these based on microbiological techniques. Now, the burning question of the moment is, why do patients with mucormycosis, with COVID-19, why do they develop mucormycosis? Why are we seeing a sudden increase? And there are several reasons for this. I'll take you through these one after the other. The first one is that the SARS-CoV-2 virus, when it produces COVID-19 infection, breaks down the epithelium within the nasal mucosa, which allows easy access for the spores of mucormycosis to enter and become invasive into the nasal passages. The second part is that COVID-19 infection itself produces dysfunctional macrophages, and macrophages are the first line of defense against any infection in the body. So their dysfunction reduces the innate immunity that a body has to fight external infection, and hence we are more susceptible to developing mucormycosis. The next part is related to the neutrophils. Again, in COVID-19, there is certain dysregulation in the neutrophils, which are the second line of defense that the body has. And these are especially more in patients who have hyperglycemia. And hence, again, the body's innate immune system is almost made dysfunctional, making it easy for us to develop secondary infections. Those patients with COVID-19 who develop a cytokine storm go through a phase where they have iron overload in the body and they have oxidative stress. Iron by itself is something that mucor loves and thrives on, and hence there could be an increase in incidence of mucormycosis in patients who develop this cytokine storm. Another reason is reactive oxygen species that are produced during the cytokine storm go and affect the macrophages and make them further dysfunctional, reducing the body's immune mechanisms further to fight any infection. And the last part is that all the other arms of adaptive immunity, such as the natural killer cells or say the platelet factor 4, all of these are affected in COVID infection. And hence your innate as well as adaptive immune mechanisms of the body goes down, and there are substances circulating in the blood such as iron, which mucor loves, and hence we are seeing more incidence of mucormycosis in patients who have suffered from COVID-19. One another thing that also happens is increase in a receptor known as GRP78 in the respiratory lining in patients who've suffered from COVID. And this receptor is the primary one which internalizes mucor, takes it into the across the epithelial cells and makes it invasive. And hence, again, we are seeing more mucormycosis with COVID. Now, when you're faced with a patient who you are suspecting has mucormycosis, how do you approach these patients? So essentially, these will be patients who would have certain host factors like uncontrolled diabetes mellitus or treatment with steroids during the phase of COVID-19 infection, or certain immunomodulators. When you see these host factors coupled with symptoms such as severe facial pain, and this is pain that they'll categorically tell you they've never experienced earlier in their life, or sort of blocked nose, decreased vision, or certain signs such as swelling around the eye, drooping of the eyelid, ophthalmoplegia, CRAO, restricted motility, panophthalmitis, or a frank palatal or nasal eschar, then these are telltale signs of mucormycosis. These patients would require a complete blood workup, especially the metabolic parameters. They would require a nasal swab and micro workup to figure out if this is invasive fungal mucormycosis or not. So essentially, what is the diagnostic pathway? So once you have any suspected or proven mucormycosis, you go ahead with imaging, and then you stage whether this patient has only rhino-orbital disease or rhino-orbital-cerebral disease. You get all the sample that you require, and this initially is from the nasal mucosa, to perform microbiology as well as histopathological techniques and figure out whether you are able to grow either mucor or see the broad fungal hyphae which are non-septate on histopathology. Now, based on all these tests, you can divide mucormycosis into possible, probable, and proven. So when you have your classic host factors that we discussed, diabetic, immunocompromised patient who presents with these signs and symptoms and has COVID infection fairly recently, then you call it as possible mucormycosis. When you have the characteristic signs and symptoms that I just told you, along with a nasal endoscopy or an MRI telling you that this looks like invasive fungal sinusitis, you call it probable. And when you have tissue diagnosis, either with the help of microbiology or histopathology, you call it as proven mucormycosis. Now, imaging, it actually forms the cornerstone of management in patients with mucormycosis. And this is a fungus which shows angio-invasion. So if you look at this gentleman who has ptosis and this little skin ulceration over here, his MRI actually shows you invasion by the fungal hyphae into the superior ophthalmic vein as well as the cavernous sinus. This is classic of mucormycosis. There are several other signs in the paranasal sinus which are very suggestive that the patient might have mucormycosis. And actually the imaging of choice remains an MRI with contrast, because it helps you easily delineate the orbital involvement when compared to CT scan, and hence pick up early orbital involvement, which is what you want to do. So there are several presentations in the orbit that you might see in the form of just enhancement in the orbit, or this form of weird fat stranding within the orbit, or at times a frank abscess in the medial or inferior orbit. Then again, at times enlargement of your extraocular muscles. However, all of these can still be treated conservatively with injections behind the eye. But if you see this sort of gross intraconal presentation and perineural presentation, then these are the patients that would progress to exenteration. Yet another patient where you see this tenting of the eyeball, look at the shape of the eyeball here and compare it to the other side, and you realize that this tenting is actually because of a gross increase in the intraconal pressure due to an abscess building up intraconally by mucormycosis. CT has a very limited role in mucormycosis and should not be used as one of the diagnostic modalities. You can read up more about imaging in our current paper in IGO. Moving on to management, all the patients with mucormycosis, whether proven or probable or suspected, go ahead with IV amphotericin B, which is initiated in all of these. Along with IV amphotericin B, they also undergo early surgical debridement of the sinuses. The eye management would depend upon how the severity of the eye infection is. And one of the most important things is to reverse their immune deficiency and to bring their glycemic control back so that they are not going into a sort of repetitive infection due to mucor. Now, these kind of patients with massive orbital involvement, there's nothing else that you can do but exenteration to give him a fighting chance to live. But if you have minimal orbital involvement, which is taking up contrast, then it means that the blood vessels there are patent, and whatever systemic amphotericin B you give along with local amphotericin B behind the eye is going to work. And this is a patient in whose case ophthalmoplegia partly reversed, and we did not require to perform an exenteration. So there is very limited literature on the role of transcutaneous retrobulbar amphotericin B in these patients. And if you were to sort of, get a synopsis of all these, then you'd realize that these are the patients in whom vision was preserved. The disease was primarily sino-orbital. There wasn't cerebral involvement, and they had localized orbital tissue with vitality proven on contrast, in which case transcutaneous retrobulbar amphotericin B works. Now, just a little word on IV amphotericin B. Though we've seen an acute shortage of drug, amphotericin B remains the first choice of drug. The deoxycholate form is usually avoided if, and this is primarily because it is nephrotoxic. However, in the absence of drug availability, the deoxycholate form can also be used. The second and third line remain isavuconazole and posaconazole. And typically the treatment continues as an induction treatment for about 1 month, followed by a maintenance treatment, which goes on for about 3 months until we deem the patient stable radiologically as well as clinically, as you can see in this patient who, after completing a 4 to 5 month course of antifungals, is stable and does not have progression. But what after the battle is won? You may still have patients come back to you with these kind of defects in the exenterated socket, which may still require some amount of intervention. And briefly, to end my presentation, I would urge everybody interested in mucormycosis to go through this recent publication of ours, which gives you 6-month outcomes in patients with Rhino-orbital-cerebral Mucormycosis, and also tells you risk factors which are responsible for a poor outcome. So to summarize, I've spoken to you about why there is an urgency involved in treating mucormycosis. What are the fungi that cause it? Why does COVID-19 predispose a patient to mucormycosis? What are the diagnostic pathways? Why does MRI stay the imaging modality of choice? In brief, discuss the management paradigm with you, cases where we go ahead with exenteration and cases where we are a little conservative and try to do debridements with transcutaneous retrobulbar amphotericin B. We spoke about the alternate drugs, and we also spoke briefly about the challenges that may lie ahead after we've won this battle. Thank you very much for your kind attention.
Thank you, ma'am.